now I need to introduce you, so hold on. So it is my pleasure it's my pleasure to introduce Dasanta Jayamani, or more affectionately known as DJ, who is a radiation oncologist. I don't know whether he's going to sing or do any tunes for us, but anyhow, he's going to be, he's from the Royal North Shore, and he's going to be introducing our international speaker. Thank you, DJ.
Thank you, Serena. Thank you, everyone. What a great delight, and what a lovely morning we've had. Two phenomenal speakers, powerhouse speakers, I must say. And for me, as a radiation oncologist, certainly my T cells and my neurons are a little bit exhausted from all the drug names that I've had to try to endure. But we're going to take a step sideways towards a radiation oncology-based discussion now in this area. And I'm going to introduce our lovely, lovely international speaker, who's an absolute powerhouse, Professor Sara Ramella, who comes to us from the campus Bio-Medico University as a professor there, and she's also the director and the department and the head of department at the Radiation Oncology Universitario campus Bio-Medico in Rome, Italy. And Professor Ramella comes to us with phenomenal experience in thoracic radiation oncology. She's internationally renowned. Her interests are in chemotherapy as well as immunotherapy, interactions with radiotherapy, as well as their interactions with targeted therapy. She's got an interest in artificial intelligence and personalization of treatment for patients with lung cancer. She's got affiliations with ESTRO, EORTC, and she's an associate editor in the JTO. So without further ado, I would love to introduce her to the stage. So thank you so much.
Dear colleagues, good morning. It's really a privilege for me to join you here in Melbourne. And please let me thank the organizing committee and the leadership of Thoracic Oncology Group Australasia for their kind invitation, and also for the fantastic assistance and hospitality. And I think that meeting like this remember us that progress in thoracic oncology is built on collaboration. Collaboration that comes over our borders, and I'm delighted to contribute to this exchange of ideas today. And on this topic, which is the role of immunotherapy or radiotherapy in immunotherapy landscape, which is surely one of the most interesting topics today that we are talking about. And here you can find my disclosure. And this talk is not it will not a comprehensive review of the literature, but it's think to be some suggestions to share with you about this dynamic duo, radiotherapy and immunotherapy. If you think about any meaningful relationship between two people, there's come a moment in which you, in which you think to know the other person, but in a moment, with time, we are surprised by them. And this is the real thing that happens also between radiotherapy and immunotherapy, because I believe that this dynamic duo can, even if we are working on this from a lot of time, we can discover some new insight into this topic. And so today the question is no longer if radiotherapy and immunotherapy should meet, but in which way we can optimize this partnership. And so I decided to address this issue focusing on three topics. First is evidence, talking about the landscape trial, which changed our clinical practice and which are common ground on which we all agree. Second, biology, because trials tell us what works, but biology explains us why it works, and this is particularly important when we have conflicting results. And finally, our future direction, because we have to reshape the possibility to cure our patients, but starting tomorrow, not waiting for a long time. What about evidence? I summarize for you some of the most important trials, landmark trials, in several settings. Starting, for instance, with stage 1 non-small cell lung cancer. I don't know if it's possible to see the slides at full screen, because I see them just a little one, so thank you. And here we summarize some of the most important trials in phase 1 together with chemotherapy. And the first is ISABR. ISABR, you can see that stereotactic treatment has been added, thank you, with nivolumab 4 cycle, and it is event-free survival. There is a benefit in event-free survival adding this treatment for stage 1 with acceptable toxicity. Keynote 867 is a negative trial. It is investigating the same topic, stereotactic in stage 1, followed by pembrolizumab for 1 year, but in this case, results are negative. And this year at IRCCS, we saw also reporting the data of the asteroid trial, in which durvalumab has been used for 1 year after stereotactic treatment, and time to progression was the primary endpoint. It was met. There is a borderline significant data, and also toxicity are quite manageable, and principally linked to the immunotherapy problem. Here I also report for you the median age of patients enrolled in this trial, because we don't know if these conflicting results, for instance, are due to the number of immunotherapy delivered after chemotherapy, after stereotactic treatment in this frail elderly patient, or for instance, we can also talk about immunocompetence in this kind of people. Here are summarized instead what are the data in resectable non-small cell lung cancer, when we try to add radiotherapy in a neoadjuvant setting together with chemo and IU. You can see that there are several trials, very low number of patients. The first is by Turkey used stereotactic treatment. Is a randomized phase 2 trial comparing durvalumab to stereotactic treatment and durva. And in this case, there is a very high rate of major pathological response in the combined arm. The other trials are phase 2 trials, so there is no comparison setting, and as you can see with Ivonipi and Durva, and a very high rate of PCR and also MPR has been reported, that probably, if we remember the number of chemo-IO PCR, can be, these data are surely higher of this. Toxicity is an issue, surely, and also the discussion together with the surgeon is a typical topic. But we can go rapidly to the chemoradiation trial in unresectable disease. In the green part of the slide, I summarize the most important landmark studies of chemoradiation with the median overall survival that are consistently 28, 29 months, RTOG, ProClimb, and so on. In the blue part, I summarize the harm coming from chemoradiation followed by consolidative immunotherapy. And as you can see, we reach a median PFS of 18, 19 months with a median OS higher than 40 months. In this part, in the pink part, I introduced the phase 2 and phase 3 trial investigating concomitant immunotherapy during chemoradiation phases. And as you can see, there is no benefit of anticipating immunotherapy during the concomitant phase. And so this is true also for small cell lung cancer, for instance. We have a lot of data on this setting, and it is something on which we have to think about, and during my presentation, we'll address also this issue. What about but we know, I don't know in Australia, but in Europe, with the chemo-IO, neoadjuvant chemo-IO, there is a big debate, what is resectable, what is unresectable, and so the choice of Pacific regimen in comparison with neoadjuvant chemo and surgery is not so simple also during the MTD, our multidisciplinary team. So there are a lot of patients coming into our clinics who underwent to chemo-IO, but surgery is not possible anymore. They have only a localized disease, and so a lot of people ask to us what we have to do. And so here summarize some retrospective, but also phase 2 trial, the Apollo and the Pacific Brazil trial, and the other experience are retrospective. What we can say, nothing about PFS and OS is too early, but I would like that you are aware that toxicity in this kind of patient are not the same of the Pacific regimen, because I've used to see something like 3%, 4% of grade 3 pneumonitis in this patient, our Pacific regimen usually, but when we start with chemo-IO, we can triplicate or reach also 15% of rate of pneumonitis. And so it's something that we have also to advise the patient and try to set up some strategies to overcome this problem. What about oligomeds? I summarized the 2-study CHEERS trial and LU002 trials, in which the first is a randomized, the second is a phase 3 trial, in which you can see that monotherapy is the timing with SBRT and immunotherapy is quite the same in the first two, because they start with IO, and then SBRT is delivered after the second or the fourth cycle of immunotherapy, when there is a response rate. And instead, the pooled analysis of Pembro-RT and the MD Anderson Cancer Center experience documented a benefit in starting with SBRT and then use immunotherapy. So timing probably is something that we have to consider. And this is the pooled analysis. You can see that abscoval response rate, median PFS, median OS are double in the combined arm. And I want to underline that what is particularly interesting for me is that this benefit is in particular in patients who are PD-L1 negative. So summarizing the literature evidence, we know that consolidative is the best. Stage 1, we have to learn, and stage 4, timing is an important point. What about the biology? Biology, I want to address the timing, sequencing, radiation fractionation, tumor microenvironment, and to remember to all of us that chemoradiation is immunosuppressive, and we have to do something to overcome this problem. Timing, we were talking about this. We have a lot of rationale to deliver radiotherapy before immunotherapy because more effective immunogenic priming can be considered. But also there is a rationale to deliver radiotherapy after starting with the IO because the adaptive immune system is in a state of readiness and probably the response rate could be higher. However, today is my personal opinion that in metastatic setting, we should think something that think about radiation as a previous treatment. What about fractionation? We know that moderate hypofractionation is able to activate the C-gas STING pathway, and so to have a synergistic effect together with immunotherapy, while if you use high dose, single dose, or high dose radiotherapy, the pathway is not possible, is not activated because the enzyme, the CTREX, clean the cytosolic DNA, and so we don't have this synergistic effect. And so also the dose that we have to choose for the treatment to be immunostimulating is of particular importance. What about microenvironment? I think that there is a fantastic publication this year in Nature, exploring the biology of cold tumors and also heavily pretreated disease according to respond poorly to checkpoint stimulating. And they analyzed data from the Pembro-RT trial. And what we can see that when we have in front of a cold tumors defined as a TMB high or low or PD-L1 null negative trials, you can see very well that the adding stereotactic to immunotherapy can give to our patients a benefit in overall survival. We can see also that in these cold tumors, immune cold tumors, there is a clear gene signature revealing that when there is a typical correlation between TMB and PD-L1 and the expression of the gene documenting the the cold state of our patients. And moreover, we have also the possibility to see that there is an abscopal in the non-irradiated tumor site in the SBRT arm, this is an important decrease in the diameter of the lesion when we use stereotactic approach also in the non-irradiated lesion. And this translates into benefit in PFS in these trials. So what about chemotherapy? Chemoradiation is immunosuppressive. We know there are a lot of biological reasons, but probably I would like to address in my final part of my talk that combination can fail simply because we destroy the immune system. Because sometimes radiotherapy can also act as a friendly fire against the immune system. And so, looking at what we can say in the biological phase is that timing and sequencing is critical because neoadjuvant, concomitant, and also adjuvant administration can alter the immune effect, that radiation fractionation, standard radiotherapy probably are not the optimal strategy to stimulate immune responses. TME, tumor microenvironment, should be reshaped together with radiation, and then we have to think about strategy to overcome the friendly fire done by radiotherapy. And so if we talk about looking at the future's direction, I told you that I would like that we talk about something that we can use tomorrow morning and not in a very distant future, because we have to think about an immuno-informed radiotherapy, what is called immuno-informed radiotherapy. What is about? We know that prognostic value of lymphopenia in radiotherapy, we know that it is true in a lot of settings, a lot of tumors, and this is correlates. Lymphopenia correlate clearly with the results, with the survival, the PFS, and also the overall survival. In particular, with the count of the lymphopenia after treatment, it is particularly important. And also here we can see that each kind of tumor has a particular way to respond to treatment. And so we can see, for instance, that is not the same between the several tumors from the brain or from the breast cancer in comparison with lung or esophagus, because each kind of tumor can have a different behavior. So I would like to address the issue of in which way we can today optimize treatment, which are the strategy to overcome and to do an immune-informed radiotherapy, talking about these four organ at risk. First of all, bone marrow. We have to consider that thoracic vertebrae is an important actor for hematopoiesis, surely, and for lymphocyte production. And so we know that irradiating also the vertebral body can affect the lymphopenia, can affect the results. And this is true. And 3 or 4 years ago, we saw also the publication, the so important project of the Lymphotech, that is a call of action to make lymphocyte-sparing radiotherapy, in which we have a lot of constraints that we can use in everyday practice to try to reduce the dose to these important organ at risk. The second organs that I want to address with you is the non-target lymph node sparing, the possibility to spare the non-target lymph nodes. We know that's why it is important, because there is the preservation, it's surely our goal when we talk about immunotherapy. And we have also an interesting experience coming from a secondary analysis of PET plant trials. PET plant trial for non-radio-onc is a trial, is a phase 3 trial comparing standard volumes to contouring with standard volumes in comparison with contouring based on PET-CT. And obviously, PET-CT consent to reduce target volume, to deliver higher doses. And in this secondary analysis, they studied the impact of mediastinal tumor burden and lymph node spread in locally advanced non-small cell lung cancer. And they documented that the radiotherapy dose to the lymphnodal station, and in particular, the lymphnodal station that are contralateral, for instance, or in the mediastinal not involved in the dose distribution, affect the results. And so this is a really interesting trial. But this trial is made with chemoradiation alone, is without immunotherapy, is nothing for that in that period we are not used to deliver durvalumab after chemoradiation. And so in this period, a lot of publication address this issue. There is a very interesting point to try to preserve tumor drainage lymph nodes in the era of immuno-oncology. You know, in head and neck cancer, this could be of particular interest because while in lung cancer, we don't use anymore elective nodal irradiation. In head and neck cancer, a lot of stations are irradiated, and so probably some insights, some observation come from that point, from that cancer, that tumor. And we also know that radiation, this is a very interesting trial, and radiotherapy induce interference with the production of some chemokines. And in this way, the draining lymph nodes are not work in the right way. And so there is a clear problem for the chemokines to activate the node, for the lymph nodes to work in a normal way. Also, in Italy, we are conducting a trial investigating in this time in patients treated with chemoradiation and durvalumab, investigating the role of the dose to non-target regions. So this is a multicentric trial. This is just a preliminary results on the first 45 patients. It is quite interesting to see that a combined score reducing the dose to some particular stations, or for instance to other organs, can predict the outcomes of immunotherapy also in this setting. What about, because if we don't want to irradiate the mediastinum, is also because we have the blood inside the heart and inside the great vessels, and the blood is full of lymphocytes. And so in which way we can try to spare this kind of non-target organs? For instance, we know from the data coming from Lamben in 2020, we know that there is a very important data on this setting, and we have also some constraints documenting that if we reduce the dose to this organ, we can also obtain better results in lymphopenia, or we can make something that we call blood sparing. And recently, you'll know that radiotherapy wants always to spare something. We started to spare lung-sparing radiotherapy, esophageal-sparing radiotherapy, cardiac-sparing radiotherapy, because we know that cardiac damage can be made by radiation, and so we studied a lot this topic. However, now we are doing a lymphocyte-sparing radiotherapy. Look at this trial. You can see that there is an advantage in overall survival if we reduce the dose to the heart, but not because we have lower cardiac events. The cardiac events are the same, so the patients don't die because of toxicity of the heart, but the superior overall survival when the dose to the heart is less is probably due to the immunomodulation, to the role of radiotherapy on the immune system. And this year, during ESTRO 2026, we saw that this very interesting data coming from the Memorial Sloan Kettering Cancer Center tried to explain in which way we can optimize the dose to the blood. What they do, they worked on in a previous trials on 155 patients cohort with locally advanced disease treated with only chemoradiation. They contoured all the blood-bearing organ at risk, contoured with AI, and they use the blood DVH. The blood DVH is particularly useful not only for each organ, but also for the total blood that can be irradiated during a treatment. And as you can see, in the multivariate analysis, they documented that the mean blood dose, but also the pretreatment number of lymphocytes can affect the results of this in this trial. And what about thymus? This is the last organ, last few minutes for me. And we saw just in April an important publication in Nature 2026 try to talk about thymic health. What is thymic health? The definition is thymic health is a prognostic biomarkers on the basis of radiographic appearance of the thymus. And this is in which way we can define this thymic health. Looking at the trials, there is an artificial intelligence system. They contour the thymus, and according to radiomics features, they are able to classify the health of the thymus. And so if it is high, average, or low. This is a very important trial conducted on more than 5,000 people patients coming from Harvard and also the Thoracic trials, that is a North American trial, North European trial, and they documented that if you have a thymus which is in high thymus health or an average thymus health, you have a better response to immunotherapy outcomes. So this is a new biomarker that we can use probably together with ctDNA, with blood biomarkers, but something that can be quite useful because of new information coming from artificial intelligence method that we use in our clinical setting. And also there are some trials investigating in which way we can spare also the thymus during with the radiation doses. As you can see, there is dose to the thymus and also dose to the duct, the lymphatic duct, impact on the difference in the absolute lymphocyte count. And so we can also try to do a model, to find a model to predict this kind of toxicity. And so, finally, in which way we can try to obtain this information from lymphoid organs, from the blood, and so on. We have a lot of discussion together with the engineer, with the medical physicist. You know that we work a lot with them. And this year in the Astro, there was a very clear presentation made by a medical physicist who works in Gustave Roussy, and she she presented this 4 slide, very summarized, in which we can see that we have some tools to evaluate the dose to the lymphocyte. The first, the more simple, is a static model that is called EDIC, and that is used in a lot of publication. Probably the best tool today is not the static model, but it is the dynamic model. This is the EDOS, and was the method applied to our MD Anderson colleague, to their trial. And in this way, we can calculate the dose, also because we know that the heart, that the blood is not fixed, and so it is important. And there are also other models, the lymphodose, and also another one considering in the model also the lymphoid organs. And so today we have a lot of tools that we can use in our clinical practice. So this is my last slide, and I hope that what I have called future direction really is not a distant perspective, but something that starting tomorrow can change the everyday practice. And because today we can do it, and we can do it together with you, because if you know what radiation oncology can give you today, you can also open your mind to new insight into the effective approach of immunotherapy. And so I want to thank you for your attention. I think that the most important things in life cannot be studied or learned, they are encountered. And so I'm so happy to be here with you, and I'm waiting with you in Rome. Right.
Thank you, Sara. That was a phenomenal talk. I think we've got a couple of questions. Shalini, do you want to go first?
Thank you, Sara, for an amazing presentation. I have 2 questions. One, in your clinical practice, are you using these new OIRs to reduce dose to the lymphocytes?
Yeah, we are. It is, yes, sorry. In my clinical practice, we are implementing EDOS, because EDIC is more simple, and EDOS, we are trying to do it because we are the leading group of the Italian multi-center trial investigating the role of dose distribution on the lymphatic organs, and so we are working on this.
My other question is, have you considered an alternative solution to reduce the rate of lymphopenia, and that would be to shorten the duration of radiotherapy from 6 weeks to a moderately hypofractionated 4-week regimen?
I'm not sure. I'm not sure that higher doses every day can spare lymphocytes. And we don't know. It's an area of research, surely. I'm very interested in adaptive approach because I want to change the volume. When we saw a shrinkage in the volume, we can spare doses. And so I think that that is one way. The other way probably is, I don't know, higher rate. For instance, the rapid arc dynamic system that can deliver the dose with less monitor units and so less time. We don't know. Flash RT probably is quite interesting.
Just a quick question. How much of the immune suppression do you feel is induced by a wound healing response when you give high-dose radiotherapy?
Sorry, I didn't understand.
Sorry, could you repeat that?
How much of the immune suppression caused by radiotherapy is due to a wound healing response to the treatment that you're giving? In other words, do you induce a Th2 humoral immune response by radiotherapy?
Because what do you think? You are talking about chemoradiation. So surely, together with chemotherapy, we have also that compound that can cause lymphopenia. However, there are some trials made only with radiotherapy, and we see that lymphopenia is important. We never talk about this, but probably if you think that we have to spare the lung, we have to spare the heart, and so the dose, we put the dose on the vertebra, typically, and in the center of the mediastinum, and so probably today we have to change our mind to address this issue, and also to consider with the new technical abilities that we have, and we can also be more conformative to the tumor. Thank you.
I think we've got a couple more minutes left, so I might ask a question as well. I mean, phenomenal talk. I think we talk a lot about the partnership between immunotherapy and radiotherapy, but then the nuances of some of the organs at risk that we don't always think about as radiation oncologists. So really phenomenal talk. How do you prioritize which organs are the most important? Obviously, the heart becomes critical for us from all the data that we've seen, but how do you decide between esophagitis acutely to get patients through the chemo-RT versus lymph node burden, versus some of the other things you said, like the vertebral bodies?
I think that today we can see that there are some toxicity that really we are able to manage very well. So esophageal toxicity is not a problem. We have a lot of way to spare esophagus with the contralateral one, all the techniques to do it, and so it is not so important. Probably with immunotherapy, I'm always so scared by pneumonitis, because patients treated with chemo-IO before radiation is a problem, and so lung is my prioritizing organ at risk. But sometimes I think that we have to think about that organs, not to try to, because if we don't think before heart, you remember before TOGA 017, we didn't think about cardiac toxicity. It will appear in 10 years, and so the patient is died. It's not important. Instead, if we think about it, and so think about thymus, think about the non-irradiated areas, and to try to spare, I think that our medical physicists can do it and make it in clinical practice.
Absolutely.
All right. Thank you very much, Sara. If you can please join me to thank her. You also have a koala.
Thank you a lot. Thank you really a lot.